Okay, good evening, Dr. Dhar. We are live, so let's start.
Yeah. Are we? Yeah. Okay.
Yeah, sir. Good evening, everybody, and welcome to this third episode of POS Rising Star. To introduce the concept and introduce the judges, I'll invite Dr. Sanjay, Dhar, President of Bombay Orthopaedic Society. Over to you, sir.
Thank you, Ashok. Good evening, everyone. Welcome back. This is I think the fourth episode of this series, BOS Rising Star, meant to nurture young talent and give them a podium to expose their abilities in public speaking, orthopedic research, as well as presentation making. So, as you know, that we have already had 3 episodes of this for arthroscopy, arthroplasty, and spine. So this is the first trauma episode where we have again, I think, 4 contestants. I'm sure the contestants know that the details of this contest. First, I'll introduce my judges today. Dr. Sangeet Gawhale doesn't need any introduction. He's a well-known trauma and joint replacement surgeon, and he has consented today to be here on the panel of judges. And I thank him for that. Welcome, Dr. Sangeet. Then Dr. Dhiren Ganjawala, again, like last time, he's there. He's one of the experts in presentation making and public speaking skills. So he will be there with us today, besides Dr. Harshad Argekar. I don't know whether he has joined so far, but he'll be there as judge.
Yeah, he is there.
Harshad is also there as a professor in Cooper Hospital, and he's a well-known trauma surgeon. And then Dr. Ashok and me will be there as POS members here. So welcome you all. Dr. Ashok will introduce judges to these presenters.
Pratik should be visible. The fourth candidate. Is he there? Pratik Tawri.
Pratik has withdrawn, yeah.
Actually, he has withdrawn, but he is still there.
He may be watching.
He's there, sir. There are 2 Pratiks. One has withdrawn, one is there.
Okay.
Pratik Tawri. Only 3 of
Pratik Tawri is there. Yeah, he's there.
of the candidates are visible. The fourth one is not visible. If he wants to continue like that, then some marks will be subtracted right away.
Maybe he will
Right,
reveal
sir.
himself at presentation time.
No, that is not fair. No?
So, should we begin with the first candidate?
Yeah, carry on.
Okay. So, I'll invite Dr. Shrey to share his presentation and go ahead.
Yes, sir. Sir, am I audible?
Yes, and your presentation is also on a full screen. Please go ahead.
Yes, sir.
Go ahead.
So, good evening, everyone. I'm Dr. Shrey Binyala. I'm a spine surgery fellow at Sion Hospital, Mumbai, and I really thank the Bombay Orthopaedic Society for giving me the opportunity to kickstart the terrific trauma session with the topic of management of open fractures, the current guidelines of immediate care. Now, we all know open fractures are fractures and fracture hematomas which communicate with the external environment. And Stanley Boyd in 1895 said that the most important division of fractures is simple, compound, and complicated are based upon the conditions of the soft parts. Why study open fractures? Now, road traffic accidents, which are the most common mechanism of injury of open fractures, are now an epidemic, one of the leading causes of loss of life and loss of limb. The mean age is affected by open fractures as 43.3 years, which is the main bread earning age of the families. Hence, we can gauge the burden to the society posed by open fractures. The objectives of our discussion today is to learn the current guideline management, and we will also go through some problems faced by our colleagues in their studies and be better prepared. as the chief determinant of ultimate outcome depends upon the decisions made and the quality of care given on the day one. The methodology for this study, it's a narrative review, and I have picked up 5 studies which I found the most relevant to this topic, 3 of which are Indian, and cross-referenced it with the literature of the past 10 years on the topic of open fracture management. The principles of immediate care of open fractures consists of manage the soft tissue injury, minimize the risk of infection, stabilize and repair the skeletal injury, and restore the function of affected extremity. How do we achieve this? We divide and rule. We divide the treatment of open fractures, the acute phase of treatment of open fractures, into 3 stages. The stage 1 is initial assessment, stage 2 being the debridement and the X-fix, and the third stage being the decision-making of limb salvage. The stage 1, the initial assessment, is based on the BOA and BAPRAS guidelines, which uses an evidence-based approach, which consists of ATLS resuscitation, acute limb management plan, and referral to orthopedics. Now, how are we supposed to do this? Now, most open fractures are caused by a high impact trauma. So the potential for concomitant life-threatening injuries should always be ruled out before addressing the trauma to the limb. Now, ATLS, that is the Advanced Trauma Life Support laid down by the American College of Surgeons, consists of a pre-arrival plan, the primary survey, which consists of airway and cervical spine stabilization, breathing, circulation, disability, exposure, and along with its adjuncts, followed by the secondary survey, which is a detailed examination from head to toe of the patient, and then the departure planning. After the initial assessment, now we come to the British Orthopaedic Association and the British Association of Plastic, Reconstructive and Aesthetic Surgeons management plan. Here we need to understand that the neurovascular examination is the most important aspect, and it is repeated again and again after every manipulation of the limb. Finally, X-rays of the limb are done after the initial resuscitation and management of the wound, and the reference is given to the orthopedics. Now, generally, we as orthopedic residents or consultants are the first contact to these patients in the casualty. But with the emergence of branches like trauma surgery and emergency medicine, we might come into the picture at this stage, and hence a formal handing over of the patient and exchange of information is of utmost importance. It is essential that the surgeon now plans the next best step in management, and for which we need to classify the disease, the classification of the injury. The classification tools that we can use are Gustello-Anderson's classification, the MES score, and the Ganga Hospital score. The Ganga Hospital score being the latest, the most extensive, and the most suited for Indian population. The GHOISS online platform is so easy to use that we can just put in the information of the patient onto the online portal, and we get a ready-made score and a treatment algorithm. Along with this, the portal also provides us with an estimate of hospital days, the treatment length, the number of surgeries, the number of admissions, the lower extremity functional score, and the time to union. Now, these things play a vital role in counseling the patient and the patient's relatives who are extremely anxious at this situation. The difficulties that we can face in this stage are that the Lancet Commission of Global Surgery sets a 2 hours time limit from admission to intervention, and 50 to 70% of open fracture patients in India are referred to a tertiary healthcare center and a trauma center, and many of these are referred from a distance more than 50 kilometers. This alone leads to a delay of more than 2 hours in about 77.6% of the patients. The second stage, that is the debridement and X-fix. Our goal here is a wound free of contaminants, and all the tissue left behind should be viable. The traditional time being 6 hours from the time of injury, but studies suggest that there is no significant difference in the risk of infection if there is a delay. The sequence of events here are temporary stabilization with an external fixator, a tourniquet inflation for better visualization and differentiation of viable and non-viable tissue, radical debridement and wound irrigation, refreshing the skin edges, releasing the tourniquet and checking the viability with the help of subdermal bleeding, and readjusting the X-fix if need be. Finally, we come to the decision-making of limb salvage, which is best taken by the plastic surgeon. Hence, it's very important to involve the plastic surgery department in the management plan and the treatment of the patient early on. This also warrants that the scoring system needs to be repeated at this stage for better outcome. And when it comes to fracture management, The damage control orthopedics is a new state-of-the-art treatment guidelines which needs to be followed, and the principles and concepts of which can be easily understood by understanding the rule of tens. The complications we face while managing open fractures are complications like regional pain syndrome, non-union, compartment syndrome, and impending amputation. But the complication that threatens us the most is infection. Debridement reduces the risk of infection. However, hospital-acquired infections are common amongst orthopedic admitted patients. Gram-negative pathogens being the most dominant in infecting the open tibia fractures, and an alarming pattern of multi-drug resistance was found in a study in December 22. How do we tackle this? A general consensus says that administration of antibiotics must be done against the local antibiotic protocol and established guidelines. To start the antibiotics within 3 hours of injury, and it may go on up to 72 hours or primary closure of the wound, whichever is sooner. And the drug of choice being coamoxiclav and gentamicin, which covers both gram-positive and gram-negative strains. To summarize the entire talk, I would like to say that the open fractures pose a heavy burden to the society, and the acute phase management is divided into 3 stages, which is of initial assessment, which consists of resuscitation and antibiotic prophylaxis, debridement and temporary skeletal stabilization, and decision-making for limb salvage. It's a teamwork, and as I said before, plastic surgery should be actively involved, and we may also need to involve cardiovascular and thoracic surgery. Damage control orthopedics is the rising star for management of open fractures. And the patient and relative counseling and psychiatric support is of utmost importance, as this is a long and debilitating treatment program. These are my references, and I would like to thank my alma mater, Bombay Orthopedic Society, and my jury to be the Vikram lander for my Pragyan rover and help me explore new horizons. Thank you.
Okay, thank you very much. Excellent presentation, and you finished well in time.
Yeah.
So now I'll invite comments from judges and questions. Gawale sir, you can go ahead with your questions.
What is new you have told? All this has been being done. We are practicing that in each and every hospital.
Yes, sir.
So there is no addition to the knowledge presentation. And is the study or what you have done, it's only review of literature, or is there a study being done at your own hospital where you're working?
No, sir, I haven't included the study that is done at my place, but this is just a review of literature
And,
that I said.
Your introduction slide
Yes, sir.
has Sion Hospital and there are other 2 centers.
Yes, sir.
So why have you added them? I think Edinburgh or some other Royal College
Yes,
has been
sir.
added. So what is that for?
So those are my institutions, sir. I have studied
Okay.
them. Yes, sir.
So how this can help us, or in giving a knowledge or adding a information? Nothing new. All this what you have spoken is being practiced in each and every hospital.
Yes, sir.
Or even a peripheral hospital.
Yes, sir.
So how this can help us? Your study can help us, or your presentation can help us.
So this was actually a presentation made on the concepts of the current guidelines for treatment, sir, and it's based on
these guidelines have already been described, published, okay,
yes, sir.
and which are being practiced regularly.
Yes, sir.
That is what I'm asking. So how that can help me or any other who are sitting in the audience? Will it change my treatment? No.
No, sir.
Will it add any information to me? No.
No, sir. Sir, it does add a little bit of information to someone, sir. It might help someone who was watching this video, sir.
Okay.
Okay, Shrey, can I just ask you a very basic question?
Yes, sir.
You mentioned that tourniquet should be used for debridement.
Yes, sir.
Is it an addition, or does it add value, or it is not a good thing to use tourniquet? Because
No,
then you will not be able to separate out the vascularized or the vascular and the avascular tissues.
Yes, sir. Agreed, sir. The tourniquet, as in the study that I read, they mentioned that they used a tourniquet to differentiate in between a viable and non-viable tissue. And at the end of the surgery, they removed the tourniquet to see the viability. And if there is a vascular injury or an arterial bleed, then at the time of removal of the tourniquet, that is going to be picked up, sir, at the time of surgery.
Just add to what Sangeet said, like you have done a wonderful review of literature.
Yes,
At
sir.
what point you think that we really need to explore or we need to study in more detail? So what are the gray areas which you identified during your
So the
review of
gray
literature?
areas I felt were that these studies have been done in major tertiary care hospitals which are fully loaded with all the equipments. So everybody who's working at a place which is not fully equipped with all these needs to understand, like the time limit guidelines that was given by Lancet, that it needs 2 hours. So if I am working in a setup where I don't have all my equipments, I have to make sure that the patient reaches to a hospital which has everything within 2 hours. Then if I plan about debridement, that it's required to be done within 6 hours of surgery, then if I am at a place where I don't have all the equipments, then I need to make sure that the patient goes to a place where there is an OT available within 6 hours so that he gets the best outcome out of that.
Good, thank you.
Yes, thank you, sir.
Yeah, Dr. Harshad.
Harshad, you can unmute yourself. Go ahead.
On his behalf, I can ask a question.
Yes, sir.
Now, see, majority of the municipal or government hospitals,
Yes,
the
sir.
presentation is usually after 6 hours,
Yes, sir.
right?
Yes,
So
sir.
if your literature is based on that part, neglected, or those who are presenting late.
Yes, sir.
So what are the complications arising from that? If you have a review of literature, that would benefit more to all of us.
Yes, sir. Yes, sir. So in the
So
study that I
some who
mentioned,
are,
yes, sir.
hear me out first.
Yes, sir. Yes, sir.
Like some who are, we are receiving patients from villages or from periphery, or for some reasons, they have been hopping around hospital and they finally reach after 6 hours, 8 hours, 12 hours. So if you focus that, how do we handle that is a common scenario here.
Yes, sir.
So we hardly receive, or even if you receive the patient, the anesthetist, availability of the theater,
Yes, sir.
okay, the medical fitness, these are the issues which are very practical.
Yes,
So
sir.
that delays the surgery beyond 6 hours, 8 hours, 10 hours.
Yes, sir. Yes, sir.
So if you can focus on that, any review of literature, that would benefit us more.
Yes, sir. So, sir, the only problem I faced in this was that I had to cram everything up in 8 minutes. Although the point that you mentioned, sir, in my study that I have also mentioned it in the slide, that where I mentioned that the debridement traditionally needs to be done within 6 hours. In that study itself, that study was the gaps in treatment of open fractures and Indian scenario. In that study, he has mentioned that in case the debridement has been happening beyond 6 hours.
Half your presentation is on things which are not related to your, the title of your presentation, right? Now, resuscitation or the other management, this is not important. All of the audience is an orthopedic surgeon who are concerned with that open wound,
Yes,
okay, and that fracture. Now, the rest of the part, the medical issues and the other extremities or the other cardiopulmonary issues,
yes,
they will be managed separately. That we understand. You have wasted your time in all that. What is more important is management of that open wound, management of that fracture, how I would deal with that.
Yes, sir.
Yeah. Dr. Shreya, have you shown this presentation to somebody or you just made and started on your own?
No, sir, I didn't take a guide.
That is where what Sangeet sir is telling you is exactly the same thing.
Yes,
You
sir.
use your thought process in making it. If you had shown to some senior person, he would have realized where your shortcomings are and had given you the right direction to correct it. That
Yes.
would have made it, these problems would have been sorted out.
Yes,
You
sir.
have 8 minutes, I get you, but in that 8 minutes, you have to present the best possible scenario.
Yes, sir.
And the time is deliberately given 8 minutes so that in that time you have to focus on the right part. If I give you 20 minutes, you speak 20 minutes on ATLS.
Yes, sir. That's true.
Right. So
Yes, sir.
that's why the 8 minutes or even 6 minutes, you have to present the relevant portion in the exact time.
Yes, sir.
Okay.
Yes, sir.
All right.
Thank you, sir.
Sir, any questions from you?
Nice presentation, Shrey.
Thank you,
I
sir.
just wanted, did you do any literature review or your own thoughts about method of fixation? When you have a compound injury, does the infection rate or recovery rate change with what different methods of fixation, like
Yes, sir.
fixator, whether you should do primary nailing or you should do primary plating? What would be the, have you studied any literature on that?
So according to damage control orthopedics that I mentioned here, sir, basically the primarily in the first 10 hours, the guidelines say that we have to do an external fixator, which needs to be converted into definitive fixation within 10 days. We get a window period of 5 to 15 days, where within the first 5 days, the surgery for definitive fixation is going to add on to a lot of stress to the body, which has undergone.
So that's what I'm saying. Did you do any literature review where this is sort of authenticated that there is a
Yes, sir. Yes, sir. I have.
Fixator is better than a nailing.
Yes, sir. That's what I'm saying, sir. In damage control orthopedics, they say that convert the fixator into a definitive fixation within 10 days, because beyond 15 days, there is.
Quoting this from any reference or any?
Yes, sir. Yes, sir. The damage control orthopedics quote, my reference number 14, sir. It consists of this, which has said that beyond 15 days, the risk of pin tract infections increases a lot. Hence, it can lead to osteomyelitis if operated later on. So the 10 days period is the time, ideal time to convert to definitive fixation.
Oh. Okay.
Yes, sir.
Okay. So we move on to the next speaker.
I'll invite Dr. Samuel to share his screen and start presenting. And we'll time it.
Yes, sir.
Screen is visible. You can go on.
Good evening, sir.
You can start.
Yes, sir. Good evening, one and all. I am Dr. Samuel. I'll be presenting a review of fixation techniques for distal radius fractures. I would like to thank the Bombay Orthopaedic Society for giving us this opportunity. The epidemiology of the distal radius fractures is about 15 to 20% of all the fractures, yet this is only a Western data. The injury can be caused either following a low energy or a high energy. The factors which determine the treatment include the patient characteristics, the fracture pattern, the fracture stability, and associated injuries. I used key terms to search in multiple reputable databases to comprehensively examine the current knowledge and to provide valuable insights on selecting the appropriate treatment fixation methods. Various classifications for distal radius fractures include the Frickman classification, the Fernandez classification, which is based on the mechanism of injury, the Madoff's classification, which classifies the fracture fragments, and the Rickley and Regazzoni's classifications, which is the 3-column classification, classifying distal radius into the radial column, intermediate column, the ulnar column, and the metaphysis has been described as the pedestal. In the imaging, we need to look for the articular involvement, the radial height and inclination, the fragmentation patterns, the carpal bones and the radiocarpal joint, the distal radioulnar joint. And if CT, if at all, it should be done only after attempted close reduction. Otherwise, we will not get much useful information. The goals of our surgical management include achieving a radial inclination, the radial height, the ulnar variance, the palmar tilt, and the teardrop angle. AAOS unacceptable reduction criteria, which was published in 2013, include a radial shortening greater than 3 millimeter, dorsal tilt of greater than 10 degrees, articular step-off of greater than 2 mm. There are certain fractures which are unstable to begin with. It is essential to identify them, as these fractures require stable fixation. These include fractures with more than 50% of dorsal comminution, more than 20 degrees of dorsal tilt, more than 5 millimeter of shortening, complete displacement, ulnar styloid base fracture, severe osteoporosis with an articular or metaphyseal comminution. The conventional treatment options for fixing distal radius fractures include close manipulation and casting, close reduction and percutaneous spinning, volar fixation, and external fixation. The other treatment options include the dorsal fixation, fragment-specific fixation, arthroscopic assisted fixation, and dorsal bridge plating. On the evidence between the various treatment modalities, the BSSH Blue Book says that there is no evidence supporting any type of treatment options for patients between 50 and 65 years of age. And for patients over the age of 65 years, the patient-related outcome measures do not reveal superior outcome following surgical intervention. On the evidence for internal fixation versus K-wire fixation, this meta-analysis shows that the volar locking plates group show better dash scores at 1 year compared with K-wires. However, the differences were unlikely to be clinically important. The UK draft trial concluded that there was no difference in patient-related wrist examination questionnaire scores in one year follow-up following K-wire fixation versus volar locking plate fixation. But there were several limitations to this study, and there were doubts if the surgeons have been unduly influenced by its headline conclusions. On the evidence for internal fixation versus external fixation, this meta-analysis showed that the flexion extension arc was better in the internal fixation group, but the difference is not clinically meaningful. This meta-analysis showed that the internal fixation group had better functional outcomes with fewer complications and recovered more quickly than the patients who underwent external fixation. There are peculiar complications associated with each of the fixation methods which need to be borne in mind. For K-wire fixation, about the pin migration, for dorsal plates about the tendonitis, and for volar plates about the compression of the median nerve. There are various plate options available, the volar and the dorsal implants, and based on the position, they may be extra-articular, juxta-articular, rim plates, or fragment-specific plates, and the locking may be fixed or variable angle. Arthroscopic assisted fixation can be used if it is a multi-fragmentary fracture with a concomitant carpal injury or distal radioulnar joint injury. Rhee et al. Proposed a useful algorithm for managing multi-fragmentary distal radius fracture. The sequence is as follows. Initially, the volar rim fragment is identified. If it is amenable for fixation, it is fixed with a volar locking plate. If not, a dorsal bridge plating or an external fixator can be used. If it is not amenable for fixation with the volar locking plate, we can use fragment-specific fixation, volar locking plate with a K-wire or a volar locking plate which is placed far distal. Then to move on to the dorsal ulnar column fragment. If the dorsal ulnar column fragment is displaced or unstable, it is fixed with a fragment-specific fixation or a pin fixation. Then the free intra-articular fragments are addressed through a dorsal approach. If there is a metaphyseal bone defect, an endosteal buttress with a bone graft or a substitute is used. Then the dorsal wall fragment is used. If there is instability, we stabilize it with a fragment-specific fixation or pin fixation. Then to move on to the radial column. If there is a volar locking plate already inserted, then we insert a remaining locking screw into the radial column fragment. If there is persistent instability, we need to go for a fragment-specific fixation or a pin fixation. Then we move on to the ulnar column. If there is a instability of the distal radioulnar joint, it can be transfixed with percutaneous pins, and the forearm is splinted in supination. If an arthroscopy is being used in the same sitting, TFCC can be addressed. This X-ray shows a dorsal bridge plate which was used to treat a shear fracture of the articular shear fracture and pins to address separate fragments. If there is a severe metaphyseal bone loss, a long volar locking plate can be used. It can also be done as a two-stage procedure if it is an open fracture where cement can be used in the first stage, and later once the infection subsides, bone graft can be used. Intraoperatively, fluoroscopic views such as the dorsal tangential view and the carpal chute view are used to ensure that the screws are not intra-articular and the screws are not impinging, coming beyond the on the extensor side so that they don't impinge on the tendons. Take home message, the evidence states that predominantly to go for non-operative management for patients over 65 years, we need to know the fractures that are inherently unstable, and we need to analyze the fracture pattern and choose a fixation method to be aware of the peculiar complications of each of the fixation methods. And we need to run through the intraoperative radiologic checklist. And the last, we should not forget the carpus and the distal radial ulnar joint. These are my references. Thank you.
Thank you, Dr. Samuel. You finished in time. Now I'll invite the judges for their questions. Gawale, sir, you can go ahead. Sangeet, sir,
Sangeet, sir, please. Sir, you need to unmute yourself.
As a to complete everything, where is he?
Yes, sir.
Yeah, Samuel.
Yes, sir.
You have missed the radial styloid. You have missed the volar lunate, management of volar lunate.
Yes, sir.
So why didn't you cover that?
I should have covered that as well, sir.
Yeah. So you covered everything dorsally, but volar you have not completed as a part of algorithm. What you have shown is very good.
Yes, sir.
So overall, like, what do we get from your paper? So except that what you have concluded in the last slide.
Yes, sir.
See, we all know that for all this, there are segment-specific fixations,
Yes, sir.
right?
Yes,
So
sir.
only what has changed or added is there is a robust literature for the age beyond 65 that can be managed conservatively.
Yes, sir.
But these are Western literature
Yes, sir.
where the osteoporosis is not as common as what we have here. So probably our age group will be little younger, say maybe beyond 55.
Yes, sir.
So if that can be studied, probably it will have a significant impact as far as giving a knowledge to the audience.
Okay, sir. Sure, sir.
Because the reason why they are putting KYs is because of osteoporosis.
Yes, sir.
And even at that age, except pin migration, there are several other complications. Loss of reduction in the osteoporosis, that is also equally common.
Yes, sir.
And maintaining in a plaster and having a sympathetic dystrophy in that elderly age group who are not actively doing physiotherapy, that is also very common. So
Yes,
you have hidden that part of the complications.
Yes, sir. Yes, sir.
Samuel, what are the issues which you think that they are really important for India, which are not covered in this Western literature?
Sir, as sir said, our population is different from theirs, and even the epidemiology, we don't have much of data from our country, though we are the largest. I mean, we have one of the largest databases. Since it's not recorded, we don't know what exactly is the predominance. So if we study our population and the difficulties with respect to the bone characters and also with the complications, then we'll be able to come forward with a criteria which would suit our population better.
Okay, and just in continuation with that, like you really reviewed the literature. Now, what are the difficulties you come across in practical application of these guidelines? Like whatever suggestions these articles have made, what
Yes.
are the difficulties which you face?
Sir, I spoke about the multi-fragmentary fractures which can be addressed with the various fragment-specific options, but there are no enough studies which have studied these using these implants. We have studies and meta-analysis only comparing external fixation and internal fixation, and even in the internal fixation group, there are not many studies which have studied dorsal fixation. We have only data from volar fixation groups.
Right. Yeah. Over to you, sir. Harshad, sir.
Yeah, Samuel, good presentation. And
Thank you,
you
sir.
covered most of the fractures related to the distal end of radius. I was quite impressed with your presentation of the algorithm. But you have to be a little more practical because you really can't follow the algorithm in a practical sense in most cases.
Yes,
What
sir.
you need to do and what you need to focus on is the practical method of fixation of these fractures.
Yes, sir.
In most instances, that would involve putting a plate on the volar side, and you have to identify the fractures where you require extra additional either dorsal or volar plates.
Yes, sir.
So that would give us a practical guideline. So I know you are not into clinical practice because you're still a resident, but a few pictures of the fractures which we are talking about rather than just the algorithm and the table makes a big visual impression rather than the text. Reading text is easy, and I'm sure you worked hard to remember that.
Yes,
but after you say it, it is forgotten immediately. So if you have some practical X-rays, it will help.
Sure.
My another question to you was, what is your reading on fixation of fragments which involve the rim, the volar rim and the dorsal rim? How do you manage these fractures?
Sir, if the volar rim fragment is amenable for fixation with a regular volar locking plate, it can be used.
It is not amenable.
If it is not amenable, we can try and see if it can be fixed with a juxta-articular plate. And if it is still not amenable, then it is a difficult scenario. Then if there is an involvement of the dorsal rim as well, then we might have to think about a dorsal bridge plate, sir. Or an external fixator.
External fixator, it really doesn't keep the fragments back in place. So there are wire fixation implants. There are implants which have a kind of a prong or pin.
Yes,
which
sir.
will be used like a plate. If you had a little bit more elaboration on that, that would have solved the question which I just asked you.
Yes, sir. Sir, I have an experience of seeing one fracture where we used small K wires, bent them, and then try to fix them. Yes.
Yes. So that is a good method. Another question which I wanted to ask you: when you put these wires, how long would you tend to keep them?
Sir, anywhere between what I have read is anywhere between 4 weeks to 8 weeks, sir.
And what are your ideas on removal of these implants at the end of fracture healing?
So one of the main concerns is infection, the pin migration. So
I'm talking about plates, and other implants which you put, not the wires. Wires obviously have to come out.
Yes, sir. So the main concerns about the plate is if it is a volar plate and if it is fixed very distally, it may be impinging on the tendons and there could be median nerve compression. Whereas on the dorsal side, if the plates are a little prominent, though the plates are generally of low profile, still there are chances that they can cause tendonitis and tendon ruptures.
So would you recommend removing all of them, or?
Sir, if the patients have experienced symptoms, then definitely would recommend removal, sir.
All right. Thank you, Dr. Sunil.
Thank you, sir.
Sir, any questions from you?
No, I think all I can say is a nice presentation, Samuel.
Thank you, sir.
Only thing I wanted to know, you have not talked, I don't know, maybe I missed it, about the die punch. Previously, we used to consider that as sort of a pivot.
Yes, sir.
That has to be restored. So in your literature, did you find and try to study that?
Yes, sir.
What is the column theory and which is the most important column in this for everybody else? Can you sort of elaborate on that, or if you have done it?
Sure, sir. The most important column is the intermediate column because it is the load-bearing column. And if there is a die punch kind of fracture, which is a volar rim, it's on the if it is on the volar side, then it can be approached via the volar approach. If it is an intra-articular fragment or a dorsal fragment, it has to be approached via the dorsal approach, and the fracture fragment lifted, and we can use a pin or a screw as a raft to keep it in position, because studies have shown that if the intra-articular step off is more than 2 mm, the onset of the risk of wrist arthritis later is 10 times greater.
And what about the radial styloid means, and what is its, how important its reduction? And what is the role of brachioradialis in such cases? So many times we release the brachioradialis. So did you study how authentic is that? Because most of us do that these days.
Yes,
but is there any literature about that this really helps?
Sir, from what I studied, I realized that releasing the brachioradialis may help us in putting back the radial column fragment in position, the radial styloid in position, but I'm not sure of the clinical importance of reducing it and putting it back in positions.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Samuel. And now I'll invite the next contestant, Dr. Abhinav, to share his presentation and start his session.
Am I visible
Yeah, your
Yes,
presentation
yeah.
is visible.
and audible, sir?
Yes.
Yeah, audible. Fine.
A very good evening to everyone. I would like to thank BOS for giving us this opportunity to present on this great platform. I'm Dr. Abhinav Jogan. I'll be speaking about compartment syndrome. So compartment syndrome was described by Volkmann in 1881. Yet 140 years later, we still, due to mismanagement or misdiagnosis, leads to thousands of amputations each year. So it is defined as increased pressure within a non-yielding osteophyseal compartment that causes impaired local circulation. So it is one of the very few true orthopedic surgical emergencies, and yet there is a lack of clarity regarding diagnosis and management. So the objective of the review was to do an extensive literature review. PubMed and all other relevant databases were analyzed, and systematic reviews and articles with high citation index were used for the study. ACS basically etiology got traumatic and non-traumatic etiologies. The traumatic are compound fractures, vascular injuries, and high energy soft tissue injuries, whereas non-traumatic are burns, casts, and iatrogenic. The pathophysiology is an increased pressure, which leads to increased venous pressure and a decreased capillary bed perfusion, which leads to a worsening edema, and a vicious cycle ensures a necrosis can happen unless we intervene with the help of a fasciotomy. But there are a bit of confusion regarding the diagnosis. So there are subjective methods like clinical examination, objective compartment pressure measurement, or both together. So regarding traditional concept of 5 Ps, these are all signs of arterial ischemia, which represent a missed compartment syndrome. Hence, there has been a new concept of 5 Ps, which involves only pain out of proportion and pain on passive stretch. So the other signs would be swelling, distension, very hard on palpation, and even if there are present pulses, it does not rule out ACS. Who are at risk? Young, high energy traumas having multiple forearm or femur and tibia fractures, or even polytraumas. Also, bleeding disorders with excessive warfarin can have excessive pressure inside the compartment. Where are the challenges? In children, they are agitated, difficult to analyze. In intubated patients with neurological disorders or regional anesthesia may not be able to have pain. So for these patients, there is development of the intercompartmental pressure measurement. So Whiteside gave a technique long back, which was a Vicks catheter. It was very easy, good accuracy and continuous monitoring was possible, but it was invasive, indirect, and there were chances of blockage. Now there are solid state transducer intercompartmental catheters, which are commercial devices, which have got good accuracy, which have continuous monitoring options, and there is a fair literature that shows good results. But they have high cost and they are requiring restoration every time we use them. So what are the guidelines for monitoring of intercompartmental pressure? The tip should be within 5 centimeters of the level of fracture. There should be measurement of all the compartments. We should do it twice at least and do it regularly. And there should be continuous monitoring to detect fluctuations in the level and durations of rise. Now, when to perform fasciotomy is the golden question. So there are 2 schools of thought, absolute pressure or differential pressure. Let's look at absolute pressure. So McQueen in a landmark paper in 1996 defined that the absolute pressure above 30, and the British Orthopaedic Association in 2017 gave the guidelines of above 40 mm as the cutoff value for fasciotomy. But this does not include the patient's BP, which may be responsible for a different perfusion pressure. So there was the other school of thought, which says a differential pressure. That is a difference between the diastolic pressure and the intercompartmental pressure, which is there between 10 to 35. And according to the Edinburgh protocol, it was less than 30 mm for a 2-hour period. But again, this does not include the trend or the fluctuations in the ICP. So what is the timing? So we all know within 1 hour, there is reversible neuropraxia, 4 hours, irreversible axonotmesis, and in 6 hours, irreversible muscle necrosis. But what we still do not know is the definition of time of onset. Hence, once we have diagnosed the compartment syndrome and we have decided to operate, within 1 hour, the patient should come to table and get operated. That is something which is very clear in literature. So going ahead, before that, preliminary measures that we need to apply are release the external dressings and casts, do oxygen therapy to increase the oxygenation, improve the BP so that the perfusion pressure is improved, and do not elevate it above the heart level to decrease the arteriovenous gradient. So what are the principles of fasciotomy? Full and adequate decompression along the complete length of the skin, decompression of all affected compartments, and assess thoroughly the viability and debride all necrotic tissues to prevent any chances of infection. Now, how to do fasciotomy is very straightforward. Literature has great agreement. The forearm, we need to go volarly by the Henry's approach and dorsal incisions. Hand, we need to go second and fourth metacarpal dorsally, and for the thenar and hypothenar, volarly. For the arm, there are 2 incisions anteriorly and posteriorly. For the lower limb, for the leg, we've got double incision 4 compartment, single incision 4 compartment with or without fibulectomy. For the thigh, we've got a single lateral incision. And for the foot, we've got multiple incisions, again in the second and the fourth compartment, and also medially for the calcaneum. Now, about the management of the associated fractures along with the compartment syndrome. So this should not be altered. If we plan to go ahead with a nail, we should go ahead with a nail. If you want an X-fix, go ahead with an X-fix. If we have to do fixation, first do fasciotomy so that there is no unnecessary delay in the management. And this stabilization would help easy access to soft tissues and also help in further healing of the fractures. Now, post-fasciotomy wound management will require dressing and closure. So let's look at dressing. The goal would be to facilitate primary closure with delayed primary closure of the wound. There should never be any constrictive dressings. There are 2 options, wet gauzes or vac dressing, but literature conclusively favors in favor of vac dressings. Now, the wound closure has to be done. If we do early, there are chances of recurrence. If we do it within 48 hours, we can complete it unless there is some residual muscle necrosis. So there are some loose tension-based techniques like the shoelace technique, which have got a risk of wound necrosis, but which require more time. The other option is split skin grafting, which causes less infection and less pain. Now, going ahead with delayed compartmental pressure, maybe due to missed presentation or maybe due to late presentation coming to us, literature says there has been around 37% of overall amputation rates when they've been diagnosed late in a systematic review. So what is the problem? There, we go in for a simple fasciotomy in an existing necrosis. There occurs uncontrolled infection and sepsis, and this may lead to amputations. So very conclusively, if compartment syndrome is missed for more than 24 to 48 hours, there is no likelihood of any surviving muscle. There is decreased compartment pressure without any infection. We should opt for non-surgical management according to the British Orthopaedic Association guidelines. Now, what are the complications? We all know workman's ischemic contracture, gangrene, postoperative skin infections like the wound necrosis and infection, and finally, amputation. So what are the recent advances that have been seen? Non-invasive methods like near-infrared spectroscopy, which measures the amount of oxygenated hemoglobin transcutaneously, new sensor technologies like radiofrequency ID tags or pH monitoring. But all of these need to be adequately validated in literature so as to be used regularly. Now, going ahead to conclusion, what we have learned, in whom to suspect, we got young, high energy traumas with burns or vascular injuries, we should be high suspicion for compartment syndrome. How to diagnose? Clinical plus continuous monitoring. Threshold for fasciotomy, less than 30 mm of mmHg of delta P over a 2-hour period. When to do it? If you take a decision to operate, do it within 1 hour. Post-operative wound dressing, VAC conclusively is decisive. And if delayed presentation more than 24 hours with no infection, go for a non-operative management. Now, going ahead for future directions, there is no gold standard for diagnosis of ACS, and that is the reason why we don't have very robust data or very high quality data. Hence, prospective mid to long-term outcome data on the different ICP monitoring protocols can really help. We genuinely need universally acceptable, clear clinical guidelines on management of ACS, which can be universally followed across all centers. Now, data in adolescents and other body parts is missing, and multimodality approach, which may help supplant fasciotomy along with the other methods, can really help us. So these were my references, and I would really like to thank everyone for the opportunity.
Thank you, Dr. Abhinav. You just finished on time, maybe 5-6 seconds more. Now I invite questions from judges. Gawale sir, you can go ahead with the question.
What you have presented is contrary to the literature. Doing a fixation while doing a primary fixation while releasing the compartments. This is contrary to what is the literature available.
Sir, literature.
No, let me complete. Hear me out first. Is there any change in the literature? Because the rate of infection, if you have fixed while doing a compartment release, is more than 50%. And that is why it is not recommended to do the internal fixation at the time of releasing the compartment. We don't know at that time how much time the wounds will take to heal, whether your implant is going to remain exposed, whether there will be secondary debridement required. So at that time, you're not clear, and hence they don't recommend, because the infection rate is more than 50%. They recommend fixation once you have closed the wound. You have said exactly opposite, that you fix all the fractures primarily at the time of compartment release. So is your statement based on any literature?
Yes, sir. So the paper that I read, sir, what they were saying was, if you're going in a compartment syndrome is a sterile environment. So primarily, we're not expecting an infection. And if we are able to, this was primarily Western literature, if we are primarily trying to going for a fasciotomy with an internal fixation with, for example, a tibia nail in a midshaft tibia fracture. So what they suggest is within 48 hours, you should try and close the wound up again. So what they're trying to say is, if you are suspecting that the patient's general condition is not good, you may not be able to go ahead and close the wound. If you are expecting to take more time for the wound closure, then go ahead for external fixation. But if you can fix it, if the general condition otherwise is good, and you can internally fix it and close the wound in 48 hours, then internal fixation will help hasten the recovery and rehabilitation process of the patient.
No, that is wrong. It cannot hasten the recovery. So you don't know the extent of compartment syndrome when you're doing a fasciotomy. Nobody knows what it is going to be, whether you will end up in a amputation, whether that compartment release is going to help the patient. Okay. So this is a vague statement that after 48 hours you take a call. So that literature is very clear about that. Except what you are quoting, a single paper, there's nothing which supports your statement. So what I'm meaning to say is, as a message, it should not go clearly that a primary fixation is advocated in when you are doing a release, compartment release. It can be deferred later once you have taken care of the soft tissues. Second issue is, you have shown a slide where there were blebs. Okay. So these are two different things. Is it an impending compartment syndrome? Now you have a fractured tibia, a distal tibia, wherein you temporarily fix, where you temporarily do a fixator, investigate, and then plan, do a CT, and then plan the definitive fixation. So, so how do you deal with those blebs, which in one of the slides it was? So this is a very common scenario where patient develops blebs, but it is not a true compartment syndrome, but the management is exactly like a compartment syndrome. That was the second question. And third was those borderline who have a pressure between say 30 to 45. Okay. There are some signs which you feel is a compartment syndrome. To me, it is not. And say to Dr. Harsher, he would like to wait. How do we handle those patients?
Yeah. So coming to the first question.
Yeah. First question you have answered. There is a difference. That is over now. We don't discuss that. Second question.
So second question, sir, you talked about a distal tibia fracture, which has got blebs, We've put in an external fixator. We are planning for a definitive fixation, but we are still not very sure regarding whether this is impending compartment or compartment. So what literature says in these such cases is we need to go ahead for compartment pressure monitoring. We need to assess the repeated examinations of the compartment, and we should wait for definitive fixation till we are very sure the patient has not developed the compartment syndrome.
So that would be informative. What you are giving now would be very informative. A regular check is what is required. And the third question.
Sorry, I just slipped my mind. Just third question. Can you please repeat it, sir?
So those which have a pressure, say in between 35 and 45, where you are not able to make a clear decision whether to go ahead with release or wait. Like I would decide to wait, Harshad will operate, you will say, I'll re-inspect, I'll postpone that. What do you do with those patients and how do they behave?
So that is actually the issue with compartment syndrome. There is no gold standard diagnosis to conclusively state that this is compartment syndrome. So different people have different modalities of treatment. The balance between over-excessive, over-aggressive fasciotomies and neglect leading to devastating complications. That is actually the crux of compartment syndrome, which still today we do not have a definitive answer to that, sir.
Harshad, you can take.
Abhinav, in your first, I think first or two slides, you said compartment syndrome are still leading to thousands of amputations. That was one statement you made. I would like to have some reference for that, because you just can't make a statement saying that missed compartment syndrome is leading to thousands of amputations unless you have evidence to back that statement. Second thing, I was a little concerned about you saying that compound injuries cause compartment syndrome. In fact, injuries which are open to the environment, you don't see compartment syndrome because compartments are naturally decompressed. Your presentation was good. It was fast and snappy, but I was totally distracted with the graphics which were going along in your presentation. They were just too much. I mean, I was wondering whether this was a serious presentation or some casual presentation for laymen who would be more impressed with what was going on the screen than the matter which you presented. So it was distracting, and I would suggest that when you're presenting to a serious audience, you should not use graphics as much as what you have used.
Why do you need this to be?
Yeah, because your matter was good. You don't need to really put it forward like, you know, it's like some kind of a game going on there. The last one of the last slides, you said that for an established compartment syndrome for more than 24-48 hours, you don't do any kind of treatment. I don't know whether we agree with that part, whether you allow it to completely go in for just non-operative, because though there may not be any signs of infection immediately, it's always a potential area where infection can occur. So just wait and watch for compartments which are completely established, and you never get a person who comes to you with after 48 hours and who has no symptoms. They have pain, they have swelling, and they do have blisters. You never get a dry, completely withered arm unless and until it is 6 months after the index event. So I don't know.
Sir, I lost sir in between.
You heard the last part which I told you, no? So I got a phone call in the meanwhile. Okay. So
yes,
my question to you is, a person who comes with an impending compartment syndrome, practically without having the use of these transducers, how do you determine what is the right time to intervene?
Yes, sir. Thank you, sir, for the questions. Sir, there were 4 questions from my understanding. The first question, sir, regarding the statement for thousands of amputation. Glass et al. Did a systematic review in 2016 in the sub-Saharan countries, within they took out the data of how many patients had to undergo an amputation because of a missed compartment syndrome. So I can provide the article that is given a 37% amputation rate, and it has mentioned about the sample size being huge. So that is how I interpreted it to be around thousands. So that was a statement backed up by a study from the African countries. The second question, sir, regarding open fractures, again, sir, I also had this similar concept of compound fractures not having any chance of compartment syndrome. But to my surprise, during literature, I found out that sometimes compound fractures, because compartment syndrome can develop in one particular compartment, and auto decompression, if it has not happened for all the compartments, it can still have a compartment syndrome wherein one particular compartment has not been decompressed because of the compound fracture injury. So there is an element of suspicion that should always be there for compound fractures for the presence of compartment syndrome as well. Regarding part 3, sir, I would apologize. I was just trying to, for the presentation being more, having more graphics, there was no element of non-seriousness about it. I was just trying to put in 100% efforts to make it more impressive over and above all the other candidates, sir. So if it was not properly, it didn't come forward, I would like to apologize for the same, sir. I'm sorry, sir, I forgot the fourth question, sir.
Which was the most important part of the whole thing. A person, how would you determine clinically when to intervene without having to use the transducers or the invasive methods, which are not available to 99% of people?
Yes, sir. I think one more question before that, sir. You told about presenting late 24 to 48 hours. So specifically, the British Orthopaedic Association guidelines have defined 3 criteria: coming more than 24 to 48 hours, with no element of infection in the wound upon inspection, and with low compartment pressures. This is the indication. These are 3 criteria. If they are met, then we can opt for non-conservative management in the form of daily dressing and suspicion of keeping it under watch and admitting and giving the proper care.
This is given by British Orthopaedic Association, where they hardly see compartment syndromes. Anyway, because they would have a system which would enable a patient to reach the hospital as soon as possible. And that sub-Saharan data, I feel you really should take it with a pinch of salt, especially data given in a Western paper about sub-Saharan studies. They are generally extremely biased and not really conclusive. In our city, in our Indian scenario, I don't think we have thousands of amputations related to compartment, because there is treatment available to most people in most instances. Yes, if they come to hospital in time, they would generally get a proper treatment.
And sir, regarding that last question, sir, again, very strong clinical suspicion, sir. Your experience upon examination, that is pretty much the only practical option available. Keep checking repeatedly, and whenever it is always better to go ahead for a prophylactic fasciotomy upon strong clinical suspicion rather than waiting and bearing the devastating complications of a missed compartment syndrome. So still keeping that
come across a little better, that you have to use your clinical judgment rather than all these monitoring devices, because they are not available to most people. And rather than having the compartment at between 35 and 40, if the pain is not relieving and it is out of pressure, out of proportion to the expected from that injury, is the time where you have to intervene. And definitely don't wait for the pulses to go away, because that will be too late.
Yes, thank you, sir.
Yeah, Abhinav, the last question, like you describe a lot of methods regarding measuring the compartment syndrome. Which method do you use?
Sir, personally, I have never had the opportunity to use the Wicks catheter. Is probably the only method that can be practiced in the ward, sir. But I have never had any experience with personally calculating a compartment pressure, sir.
Okay, thank you. Yeah.
Thank you, sir.
Dr. Dhar?
Yeah,
Any questions?
Nice presentation. I might, from literature or from your own experience, could you find any correlation with any biochemical markers or anything which can be simultaneously studied if you don't have these methods of? Is there anything which guides you on that?
Sir, the management of compartment syndrome primarily has 2 serological markers, urine myoglobulin and creatinine phosphokinase, which is an indirect marker for muscle protein breakdown. But there is no way to directly diagnose or predict compartment syndrome.
From the literature, could you find anything on this, that there is some?
There are a few recent advances regarding a lot of different markers, but nothing significant, nothing really that can be conclusively used in practice or that can be thought of as worth applying in a practice, sir.
Could you find any paper or literature, what those 5 Ps, what we see, they have any relationship with the pressure? Is there any scientific paper on that or something you could study?
So, sir, basically
simultaneously, so you have, all of us are more, as Dr. Arshad said, the 99% don't have access. So is there any scientific paper like in literature where you could have any relationship of these 5 Ps with pressure markings or something like that?
That's one paper that I read had a direction of future that really said that we need to find out the correlation of each of these physical signs of 5P with the compartment pressure as a future directive, which was a 2022 paper, I think, sir. But there is nothing as of now in literature, sir.
Okay. Okay. Thank you.
Thank you, sir.
So the fourth one is joined. The fourth candidate is joined.
So,
Yeah, he's there.
Yes, sir, I'm there. Hello.
Nice. You joined late.
Yes, sir.
I think you are joined late.
No, sir. I was there throughout the session, sir.
okay,
I kept
go ahead
it.
and share your presentation.
Sure, sir. Thank you, sir.
Yeah, go ahead and share your.
Just a second. Hello.
Yeah, go ahead and share your presentation.
Yes, sir. Share screen. Yeah. Okay. Good evening, everyone. Sir, is it visible?
No.
Your presentation is good.
Okay, sorry. I was yes, sir. I was actually okay. So now it is present. Good evening, everyone. Thank you for giving me the Bombay Orthopaedic Society for giving me this opportunity to speak upon the acetabular fractures, its classifications, and the clinical relevance. I am Dr. Pratik Sunil Tawri, trained at Bombay Hospital, Mumbai, and currently working as a senior resident at GMC Nagpur. Let us go back to the history and see that Dr. Robert Jude's work and Professor Dr. Emil Luternel's work, which has brought the Professor Dr. Robert Jude and Professor Dr. Luternel has in 1964 came up with a seminal work on the fracture of the acetabular classification, and which is still considered as the gold standard classification. Prior to this, there was no proper classification system, and it has led to increased number of failures. I reviewed my literature through PubMed and Google Scholar for the recent last 10 years articles. The cross references were studied. Luternal textbook of acetabular classification, acetabular fracture was reviewed, and the studies with high citation index were chosen for the study. I came across various classification systems described in the literature, apart from the classical Luternal and Jude classification. Those are AO classification, the Harris CT-based classification, the Herman classification, and the Zhang 3-column classification. AO has classified it in 3 types, but this classification system has many subtypes, and it is a more complex classification system. It has a low inter-observer and intra-observer diagnostic reliability and reproducibility, and due to which there is limited clinical applicability of this classification and more of a research-based purpose. Harris in 2003 came up with a CT-based classification, and this classification is based on the Luternal classification, but this did not improve the utility in determination of surgical approach or patient outcome according to this. In 2018, Herman came up with a no-column classification. So this was based on the displacement vector velocity, but only considering the displacement vector pattern as a primary fracture pattern, it may go misleading, and the clinical outcome or the clinical approach chosen can go wrong. Zhang in 2019 came up with this 3-column concept, which was based on the original Luternal and Jude classification.
However, this was to include all the unclassified patterns of the lateral and jude. This was a more complex type of classification. And therefore, Zhang himself has suggested in his study that this should be used as supplement to the original classification. So what is this classical lateral and jude classification? This classification is based on the morphology and the force of direction, which is divided into elementary and the associated types. To understand this classification, first we need to understand the column concept, which is the complex 3D anatomy of the acetabulum. This column concept consists of the anterior column and the posterior column along with the sciatic buttress. The anterior column consists of the anterior part of the acetabulum, the iliopubic part, and the superior pubic rami. And the posterior part of the acetabulum, posterior column consists of the ilioischial line, the ischium, and the posterior part of the acetabulum, and the sciatic buttress. The classification is based on the elementary type and the associated fractures. The elementary fractures are the axial fractures, which consists of only one fracture pattern. That is the posterior wall fracture, where only the posterior wall is broken from the entire acetabulum. The posterior column fracture, where the posterior column is broken from the entire acetabulum. The anterior wall fracture, where the anterior wall is broken from the entire acetabulum. The anterior column fracture, where the anterior wall along with the inferior pubic rami is broken, and the transverse type of the fracture. The transverse type here included in the elementary fracture is because this fracture variety has a connection with the sciatic buttress, and therefore it is not dissociated from the axial skeleton. The other classification, the other part is the associated fractures. That is the posterior column along with the posterior wall, the anterior column along with the posterior hemitransverse, the T type of the fracture, which is the transverse along with the inferior pubic rami fracture, the transverse fracture along with the posterior wall, and both the column fractures, where the acetabulum is a floating acetabulum because it is not in connection with the axial skeleton. For better understanding of this classification, we need to understand the basic radiology. Basic radiology consists of the pelvis AP X-ray, which consists on which we have to see the 5 lines. That is the iliopectineal line, the ilioischial line, the teardrop sign, the anterior lip, the posterior lip, and the sourcil sign. Apart from this, we have to study the jude view, that is the external and internal rotation of 45 degrees in orthogonal position. The views are iliac oblique view and the obturator oblique view. On the iliac oblique view, we can see the greater sciatic notch and the lesser sciatic notch along with the posterior lip. And on the obturator oblique view, we can see the ilioischial line along with the anterior lip. Lie and has suggested a algorithm based on these lines to understand a better way this jude and lateral classification. So this was based on the, first we have to understand the iliopectineal line. Okay, so if iliopectineal line is intact or broken, if it is intact, then only the posterior part of the fracture is, then only the posterior part of the fracture is intact and the anterior part of the fracture is broken. And then we see the ilioischial lines. The ilioischial lines are the the ilioischial line. We see that if it is broken, then we can identify that there is a complex variety of the fracture pattern. And if in the if both the lines are intact, then we can see that the posterior wall is broken and not the posterior column is broken. And the third part of the component is of this algorithm is the inferior pubic rami fracture, which will suggest that if it is broken, then there are complex varieties of the fractures. That is the associated fractures. So now, what classification system should we follow? On reviewing all the classification system based on their classification system, the types, reproducibility, comprehension, understanding, and the clinical relevance, we can come to identify that all the classifications are complex. The understanding is difficult. However, the reproducibility rate of Judean lateral classification is high, and it is simple to comprehend. And the clinical relevance is 95%. So to make this understanding a simple one, we can go along with the algorithm. And various societies across the globe, the pelviacetabular societies, the trauma societies, have accepted the Jude and Latournette classification and follow that. So Jude and Latournette classification system has stood the test of time and still remains the gold standard for classifying the fracture acetabulars. We just need to thoroughly understand the column concept and simplify the learning process. These are my references. Thank you.
Thank you, Dr. Pratik. And you took around 30 seconds more to finish your presentation. I'd like to invite judges for their questions.
Now, your presentation was on presentation was on classification and its relevance.
Yes, sir.
And half the time you have spent on describing the anatomy, the radiology, which is, which has taken majority of the time, and you concluded the relevance in only last slide. So we would have appreciated if you would have elaborated the relevance of significant relevance and the significance as regards to your topic which you have chosen for presentation. You have concluded everything. Even if you would have presented the last slide, last two slides, that summarizes your talk.
Actually, sir, to crux the whole. Yes, sir.
There are so many new things have come up. There are so many new fractures which have not been described by Jude. They have come up. So if you would have elaborated on that, added to that, and given a proper algorithm of relevance, that would have helped, or that will help the audience.
Okay, sir. So I understand.
It was not a lecture. It was not a lecture. So there was no need to describe the anatomy. There was no need to describe the radiology.
Actually, sir, I thought because the classification system based on the Jude needs the understanding of the anatomy first, because apart from that, we cannot, basically the understanding of the anatomy is the prima facie of the understanding of the classification, and understanding of the classification is the prima facie for the clinical application or the approach we choose.
You all know that. You all know that.
Yes, sir, I understand. Because there are, I went through the literature, so I just got what point you tried to mention. There are few more classifications based on the quadrilateral plate. So that is also a newer classification that is there in the literature. And but even the classification on the quadrilateral plate that is just published in 2021 article. Even that article has said that
presentation, hear me out. So your presentation should add knowledge to the audience. Your presentation should give new information. It should give a good review of literature. So what you have concluded is all old what we know about. Are you understanding?
Yes, sir. Yes.
So basically,
yes, sir. I should have included that quadrilateral plate classification part, and the newer classification, the 2-3 more classifications are there. I should
why you are called on a Bombay Orthopaedic Society platform is you're supposed to give something additional, something new, something informative.
Right, sir.
Right. So this is all what you have spoken is already known in the literature. You're presenting a review of literature. You understand that.
Okay, sir.
Dhiren sir.
Yeah, first of all, excellent animations. I really appreciate the way you showed the things. But what Dr. Sangeet said is absolutely right, that there was nothing new message. So that's the only thing. I don't have a question to ask for that. Yeah. Dr. Harshad. Yeah.
Yes. Pratik, to be very blunt, I don't think you will be a rising star here, because your presentation was subpar from what we expect at this forum. This was not anywhere close to that. We all know the classification, we all know the anatomy, we don't need to know the lines. We need to know how to use the lines to come to a conclusion as to what the fracture is all about. So that should have been the focus of your presentation.
Sorry, sir.
What did you hear what I said?
No, sir, it was a little hazy voice.
Okay.
Yes, sir.
So my first few lines were not very polite.
No, I could hear that, sir. The last part I couldn't.
The rest you don't need to understand. Rest you don't need to understand.
What I basically told you was that you should have been more focusing on how to use those lines to come to a conclusion as to what fracture you're dealing with. What I would have used is I would have shown a few X-rays and then analyzed them as to what fracture pattern it falls in. That would have been more towards what the topic was all about. And you have completely missed about on the seagull sign and the protrusio part, which is actually relevant in today's picture, because that is what gives the prognostic value.
The gull sign, the post superior part. Okay.
See, your time of speaking is
I
over.
reviewed,
now it is
but
my time of speaking. Pratik, your time of speaking is over. Now you have to listen.
Yes,
so
yes,
don't
sir.
interrupt.
Sorry, sir.
So what I was telling you is that you missed on all these parts, and just think about it for the future whenever you get such an opportunity. Thank you.
Sure, sir. Thank you, sir.
Very good point to all four of you. What Harshad is mentioning, that instead of like the clinical photographs or the review or the article, the pages of the article, if you like as an orthopedic surgeon, we are more used to seeing X-rays, right? So if you have a representative X-ray of a classification or of type 1, type 2, type 3, that is more appealing to us as an audience, that is more informative, and that is more practical. So in your talks, you must include a case study or a case example. That is a very relevant point, which was missing, except I think Samuel's, where he has shown only one X-ray in which he has used an internal fixator. Right. Rest, all of you, the X-rays were missing. Relevant X-rays were missing, which as an orthopedic surgeon, we are used to seeing them. If you can describe a classification on that X-ray, that would have been more relevant. President, sir, to conclude.
Yes, sir.
Yeah, a good attempt, Aditya, sorry, Pratik. Only thing is, see, acetabulum is a very complex subject even for the presenter. So you have overloaded it with everything and got yourself confused because you were struggling at some point. So, and your graphics were quite good, but then don't overdo it. You put the finger on the point. There was no need. Even the line was good enough to see us. So we are, as Dr. Sangeet said, that we are orthopedicians and we are very highly egoistic. So you don't flood us with everything. So so you should have made it a little simpler. I think it was your first attempt probably, and I'm sure you'll learn from it. Overall, that is why it is a very complex subject, so it should be made simple. So your job as a speaker is to make it simple for us. So even though we know many things, but then it would have been very crisp if it was a smaller. But anyway, good attempt. All the best.
Mostly, sir, I would just like to conclude that mostly all the points from the.
Hello.
I have,
One second. There's no need to give explanation for each.
no,
and
sir,
every-
I'm not giving explanation, sir.
We don't expect
I
that.
just couldn't.
Now you have to hear. Now you
okay,
have to hear.
Yes, sir. Yes, sir.
Your talking time is over.
Yes, sir. So I'm not
Don't
explaining.
have to give explanation to each and every.
No, okay, sir.
No problem. All the best. Yeah.
Thank you, sir.
But like say, I must say that all the four presenters, like if I put myself at your age, you are definitely much more
Yeah.
better than what I was. So I really appreciate your good skill. And I'm sure that with the so many mentors around you, you are going to flourish your presentation skill in future.
Thank you, sir.
Yeah, I would also like to say something. If we have been a little critical or a little harsh in our statements, it is not to put you down, but it is to, at this stage, give you a direction to improvement, because nobody told us when we were at your age. If somebody had put me down when I was presenting my first presentation, I'm sure I would have improved much earlier than what I am today. We would have been in a much better position. So the aim of the criticism is not to put you down, and definitely we are not looking for explanations for what you've done. You just have to take it as what we have said, as a stepping stone to get better in the future. That is all that this is all about.
Yes, sir. Thank you, sir.
Thank you.
And
Thank you, sir.
I'm sure all of you will be on a platform sooner or later in years to come of the Bombay Orthopaedic Society, and you will be part of VIROC in the future. So don't worry about that. Wish you all the best from all our judges. Okay.
Thank you, sir.
Thank you, sir.
Thank you, sir.
President, sir, you can conclude.
Remarks and
Yeah, once again, thank you to all the judges, Dr. Sangeet, Dr. Dhiren, Dr. Harshad, for taking time out of your busy evenings. This is Friday evening. So, and thank you all the participants for being there. The fact that you have reached this stage means you are bold enough and good enough, and I'm sure you'll go all the way higher. So all the best, and thank you, Shyam and Dr. Neeraj and Dr. Maharishi for allowing this to happen. Thank you very much. And good night.
Thank you, and all the
Thank you,
best,
sir.
and
Good
good
night,
night.
sir.
Yeah.
Thank you, sir.
Thank you, sir.
Good night, sir.
Good night.
Good night.
Should the faculty also log out, or we're waiting only for the delegates to log out?
No, faculty can also log out.
All right.
Your marks
Thank
will
you,
go directly to Ashok.
All right. Okay, sir.
You don't have to declare the winner here.
Okay. All right.
Thank you. All the best.
Bye. Bye.
Thank you very much.
Yeah. Good night. Bye bye.
Thank you.
Yes.